Hello, dear students and friends. The topic for my presentation today is labor analgesia. We know that childbirth is a normal life event, yet it is considered to be one of the most painful experiences in a woman's life. In my talk, I would be highlighting some important pain management strategies in labor. So, labor analgesia and an unmet right of a laboring woman. It is said that moms go through the worst pain ever in order to give birth to the best gift ever, the child. Well, if you look at statistics, a human body can bear only up to 45 dells of pain. Yet, at the time of giving birth, a mother feels up to 57 dells. This is similar to 20 bones getting fractured at the same time. So, can you imagine the mother's pain and yet the love for her unborn child? A woman's ability to cope with labor pain appears to be influenced by her parity. There are complex psychosocial factors like fear, anxiety, her prior experience of labor, her culture, ethnicity, presence of emotional support, antenatal class attendance, and even educational attainment. There has been a rising trend in the levels of advanced care for women in labor. And in coordination with that, there are pain management strategies like which are non-pharmacological, they could be pharmacological, and even regional analgesia is invoked nowadays. If you go back to history, the use of non-pharmacologic and pharmacologic agents to provide relief from labor pain has been known since time immemorial. Until the early 1900s, most children were delivered at home, and pain during labor was managed mainly by non pharmacological methods. Then, starting from mid 1800s, there are records indicating the use of pharmacological agents to attenuate labor pain. Initially, chloroform, which is a volatile gas, was used to treat labor pain. It was even adopted by Queen Victoria of England and was then referred as chloroform a la Reine. Now, coming to the cause or the reason behind these labor pains, there are three physiological explanations. First, there is myometrial ischemia during uterine contractions, which may cause pain, cervical, vaginal, and perineal stretching, and distension of other perineal structures also is responsible for the pain. The type of pain changes as labor progresses. During the first stage of labor, visceral pain predominates. Nociceptive stimuli from the cervix, uterus, adnexa, and pelvic ligaments are transmitted through the sympathetic fibers to the posterior nerve root ganglia of T10 to L1. Then, during the late first stage and early second stage, when the pain is most severe and most intense, there is distension and traction of pelvic organs. Pain stimuli are transmitted by the pudendal nerve through the sacral plexus to the posterior nerve root ganglion at spinal levels S2, S3, and S4. The second stage of labor, while the fetus descends and it distends the perineum, this induces pain because of stretching of perineal structures. Then these labor pains do have effects on the mother and fetus. In addition to pain, there is associated stress as well. This causes increased sympathetic stimulation, there is hyperventilation, respiratory alkalosis, and at times there are apneic episodes in between contractions, mainly could be because of systemic opioids or sedatives which are given. All these things cause increased free fatty acids, hyperglycemia, metabolic acidosis, uterine vasoconstriction, decreased placental blood flow, left shift of oxygen dissociation curve, and maternal hypoxia. Because of this, there could be associated fetal metabolic acidosis and fetal hypoxia. An important factor that affects pain sensation in women and selection of analgesia is their sense of control over their body and labor process. Some women may feel intense pain in the beginning, but for some, they may not feel pain till the end, till they come in full dilatation. Now, coming to the various non-pharmacologic methods, they are popular and They complement pharmacological and principal analgesic treatment. Studies have shown a positive impact of complementary and alternative medicine approaches to relieve pain. Worldwide, nearly 73% of women use at least one non-pharmacologic method for pain relief during labor. The reported leading methods are breathing exercises, which are being used in 48%, position changes 40%, hands-on techniques like massage 22%, mental strategies, relaxation by music, aromatherapy, etc. in 21%. However, there is currently a little very less high quality evidence supporting their efficacy. So these are the various positions a woman can adopt during labor. She can be in the position in which she feels less pain and in which she is comfortable. Standing, sitting on a birthing ball, squatting position, kneeling position. And recently, peanut ball has been introduced. This also helps in achieving a position she wants, like semi-sitting, side lying position, on floor position. She can sit on the ball, hands in knee position, tuck position. So with the help of this peanut ball, these positions are very easily possible. Then the other methods, relaxation techniques like breathing exercises, yoga, music, hypnosis. Their main aim is to relax the body and reduce blood pressure and breathing rate, and so increases the sense of well-being. Various manual techniques like massage, reflexology, even the Thai massage, which is known as shiatsu, warm and cold packs. According to systematic reviews of many RCTs, thermal manual methods like warm packs and massage may reduce pain and increase emotional comfort, though the level of evidence is again quite low. Acupuncture, a traditional Chinese method in which needles are inserted in different body areas, they help in addressing imbalances of energy. Acupuncture also may help. Then the birthing ball. A birthing ball is a large exercise ball that women sit on to perform movements such as rocking and pelvic rotation, which may help in reducing pain. The use of transcutaneous electrical nerve stimulation. These are application of electric currents to the surface of skin, leading to pain reduction by multiple mechanisms, including blocking of pain signal transmission and release of endorphins. So these were the various non-pharmacological methods. Now coming to pharmacological methods. The use of nitrous oxide, that is commonly called as gas and air. Non-opioid analgesics, which are acetaminophen and non-steroidal anti-inflammatory drugs, NSAIDs. The use of opioids, patient-controlled analgesia, and regional analgesia, epidural or spinal. Now coming to nitrous oxide. This has been widely used worldwide for labor analgesia since several decades. Its analgesic effect is achieved by stimulation of neuronal release of endogenous opioid peptides by activation of postsynaptic opioid receptors. So it stimulates the opioid receptors and opioid peptides are released. The commonly used blend is a combination of 50% nitrous oxide with 50% oxygen taken by a self-administered facial mask. The parturient attaches the mask to her nose and mouth. With inhalation, a demand valve opens to allow gas delivery, which closes with exhalation. The correct timing of inhalation is essential because analgesic effect takes 30 to 60 seconds to be effective. Nitrous oxide is rapidly cleared from the blood of the mother and newborn, which makes it safe to use throughout labor. It does not influence labor progress, mode of delivery, or neonatal outcome. When given in this ratio 1:1, it has a very good safety profile. However, there are certain adverse effects which have been noted, which include nausea, dizziness, and drowsiness. So this is how it is given, and this is how, by stimulating the opioid receptors, its mechanism of action. Now coming to the second method, the use of opioids. They are widely available, easy to use and of low cost, and are commonly being used for pain relief during labor. Their main advantage is that they produce analgesia with milder effect on sensation and proprioception. There are three classes of opioids: natural opioids, obtained from poppy plant include morphine, codeine, and piperacillin. Semi-synthetic ones, in which there are minor modifications of morphine molecule that including heroin, that is dimorphin, dihydromorphone, thebaine derivatives like etorphine, buprenorphine. Synthetic ones which are being used are levorphenol, butorphenol, then methadone, meperidine, fentanyl, sufentanil, L-fentanyl, and remifentanil. Out of this, remifentanil is the one which is now being commonly used. The opioid use during labor is associated with maternal side effects, nausea, vomiting, pruritus, sedation, and at times respiratory depression. Opioids cross the placenta and may lead to reduced fetal heart rate variability. Reduced baseline fetal heart rate, they may cause neonatal respiratory depression. There are incidences of lower APGAR scores, neurobehavioral alterations, and decreased early breastfeeding, basically because they cause lots and lots of sedation. So this chart depicts the dosage and kinetics of opioids, which are commonly used. You can see that remifentanil has a duration of action 3 to 4 minutes and an elimination time 9 to 10 minutes. So it is considered quite safe. Women who are interested in efficient contentious pain relief and they do not want epidural analgesia, they can be offered remifentanil patient control analgesia during the first and second stage of labor owing to the short half-life. Boluses delivered in a dosage between 0.15 and 0.5 milligram per kg with 1 to 5 minute lockout appears to be the most efficacious patient control analgesia regime. Even then, close monitoring of respiratory depression is required. Now coming to the next option, which is regional analgesia. This represents the gold standard of intrapartum analgesia. Regional analgesia was first introduced in 1960s and includes epidural, combined spinal epidural, and spinal analgesia. So it's same as anesthesia, which we are using for various surgeries, but the dosage is quite less, and so the patient does not feel pain and remains mobile. Epidural anesthesia involves the use of local anesthetics with or without an opioid injected into the epidural space to produce a reversible loss of sensation and motor function. Local anesthetics inhibit nerve conduction by blocking sodium channels in the nerve cell membranes, thereby preventing the propagation of nerve impulses. So this is the mechanism of action. Since 1980s, the advent of lower concentration of local anesthetic solutions in combination with a variety of opiates like 0.0625 to 0.1% of bupivacaine and 2 microgram per ml of fentanyl. This combination has vastly reduced the adverse effects of epidural anesthesia in labor and has improved maternal satisfaction. Improvements include retention of motor function and even the ability to walk during labor, which is called as mobile epidural. So as in first and second stages of labor, if the patient is mobile in the first stage of labor, she remains more active and it is better for her. So this is how mobile epidural would be helpful in these situations. So in the second stage, this has better ability to bear down and also reduction in hypotension and its accompanying adverse effects. These are the various indications for regional anesthesia based on guidance from Obstetric Anesthetists Association. Indications include maternal request, expectation of operative delivery, then maternal cardiac and respiratory disease. It is a good option. Preeclampsia, trial of labor after previous lower segment cesarean section. In some neurological conditions like intracranial intra-arteriovenous malformations, in preeclampsia, breech delivery, or multiple pregnancy. When general anesthesia is contraindicated, like in cases of morbid obesity and in cases of intrauterine death, it is a good option. Various contraindications include maternal refusal, local and untreated systemic infection, presence of coagulopathy, platelets less than 80,000, INR more than 1.4, uncontrolled hypovolemia or hemorrhage, expectation of significant hemorrhage, certain spinal surgery and spinal abnormality in the past, if she's had, lack of trained staff to provide safe care. The maintenance regimes for epidural anesthesia containing a low concentration of local anesthetic agent with opioid solutions can be administered in one of the three methods. So it has to be a continuous infusion of these medications. It can be done by intermittent top-ups, midwifery top-ups, or an anesthetist can intermittently top up the drug. Patient control epidural pump, or continuous infusion with or without patient-controlled epidural pump. The use of patient-controlled pump allows the woman to be in control of her pain by self-administered top-up. So when she feels pain, she pushes the button and then she gets a top. These pumps are pre-programmed with a set dose and a lockout time, usually 30 minutes, which avoids high blocks and toxicity. So the two commonly used methods for analgesia and the ones which are safe are epidural and remifentanil controlled analgesia. Remifentanil patient controlled analgesia. In epidural, an anesthetic agent is infused through a fine plastic tube inserted into the epidural space L4, L5 or L5, S1. It takes 20 minutes to set up and 20 minutes to work, and is given in those who are in established labor. Caution should be taken if previous spinal surgery or if she has clotting disorders. Continuous fetal monitoring is required, intravenous access should be there, and continuous blood pressure monitoring is essential. It provides most complete pain relief of all the various methods. It is non-drowsy, no neonatal drowsiness, and top-ups for extra procedures in theater such as a cesarean section with no extra injections. Only a top-up is given and you can do a cesarean section immediately, shift her to the OT and do it. The adverse effects include failure to work 1 in 10, pruritus and shivering, significant hypotension which may occur in 1 in 50, severe headache 1 in 100, temporary nerve damage 1 in 1000, permanent nerve damage 1 in 13,000, infection, meningitis, epidural blood clot less than 1 in 50,000. Now coming to the second option, remifentanil patient control analgesia. It is an ultra fast acting opioid type of drug, and so the effect is almost immediate. IV access is required and that is attached to a PCA pump. This provides pain relief on demand. It takes only 5 minutes to work. In some cases, additional gas and air would be required in 1 in 8 women. Again, it is given to those who are in established labor, contraindicated if morphine or pethidine is given in the previous 4 hours. Caution if heart problems or allergy to pethidine or morphine. So if there is allergy to opioids, then it cannot be used. Continuous monitoring, however, is not required. Oxygen saturation monitoring is required in these cases because respiratory depression can occur. It promotes a feeling of maternal relaxation and sleepiness and is considered safe for the fetus. The adverse effects include failure to work, same 1 in 10, pruritus, nausea and vomiting, drowsiness and dizziness, may cause neonatal drowsiness, can cause a reduced respiratory rate with the requirement of supplemental oxygen. Stopping the use of PCA pump may be required because of hypoxia and reduced Glasgow coma scale in 1 in 28 women, and there could be cardiorespiratory arrest, a rare complication in less than 1 in 2200. To summarize, of the various pain relief methods in labor, what evidence tells us? Those shown to be effective are epidural, combined spinal epidural, continuous one-to-one support, like presence of a relative or a person to assist the woman during labor has been seen to be very effective because the woman is comforted. At times they rub her back, and this helps in providing more of emotional support and relaxation, which is effective in pain relief. Those methods which may be effective include music-assisted relaxation techniques, birthing ball or upright posture, water immersion, water birth is also another option, nitrous oxide, relaxation techniques like massage, acupuncture, acupressure, non-opioid methods, sterile water injections, and remifentanil patient control analgesia. Insufficient evidence for these techniques are transcutaneous electric nerve stimulation, biofeedback, hypnosis, aromatherapy, oral or parenteral opioids. So whenever a woman goes in labor, there are uterine contractions, which are associated with dilatation and thinning of cervix. And all of this causes tremendous pain, lots and lots of pain. And this pain has to be managed in a variety of ways. The take-home message, analgesia in labor plays a crucial part in affecting maternal satisfaction during one of the most painful periods of a woman's life. The key to providing the best possible analgesia for the laboring women is the provision of appropriate and relevant information on labor analgesics and continuous one-to-one support from a trained individual provider during labor. So the most important thing is that we need to explain to the women the various techniques. She can choose one of those techniques and she must have one-to-one support from a trained provider. While a number of pharmacological and non-pharmacological options exist for labor, epidural anesthesia remains the gold standard for severe pain. Over the last decade, the biggest changes in labor analgesia have been the spectrum of non-pharmacological treatments available and the advent of remifentanil patient control analgesia. So in the end, what we want is a healthy mother and a healthy baby, a healthy and satisfied mother who has not had much pain in labor so that she can take care of the child and she feels happy after her delivery. Thank you. And if you've liked my presentation, please do subscribe to my channel. There are many more presentations to come.